Hypernatremia is defined as a sodium concentration greater than 145 milli equivalent per liter. All patients with hypernatremia have hyperosmolality. The causes of hypernatremia may be divided into extrarenal water loss, renal water loss, and iatrogenic hypernatremia results from the addition of hypertonic sodium. Patients with hypernatremia caused by extrarenal water loss often have decreased extracellular fluid volumes as well, indicating deficits in total body sodium as well as water. The proportionally greater deficiency of water than of sodium leads to the increase in the serum sodium concentration. The most common causes of hypernatremia due to extrarenal water loss include fever, profuse sweating, hyperventilation, including mechanical ventilation, and severe diarrhea. The hallmark of marked renal water loss is polyuria, defined as a urine volume greater than 3 liters per 24 hours. The common defect in all cases of renal water loss is an inability of the kidney to conserve water appropriately. The key to the evaluation of the patient with renal water loss is measurement of the urine osmolality. The excretion of an osmotic solute load by the kidney will obligate a certain loss of water. Polyuria is an important clue to the presence of an osmotic diuresis. A helpful clue to the presence of an osmotic diuresis is the osmolality of a spot urine specimen. It will generally be in the range more than 300 milliosmol per liter, and may have a sodium concentration in the range of 50 to 80 milliequivalent per liter. Patients with hypernatremia due to osmotic diuresis often manifest clinical signs of ECF volume depletion. Central diabetes insipidus is due to deficiency of ADH. It is associated with severe CNS structural lesions or infections, head trauma, or pituitary surgery. The onset of polyuria may be abrupt, with large urine volumes. Vasopressin will result in a significant decrease in urine volume and an increase in urine osmolality. Nephrogenic diabetes insipidus implies unresponsiveness of the kidney to ADH. It occurs in a number of interstitial renal diseases, electrolyte disorders, and in response to certain medications. The urine volumes are often less than those seen with central diabetes insipidus. Iatrogenic hypernatremia differs from the other categories of hypernatremia in that it is caused by gain of hypertonic sodium. This usually occurs in the critical care unit or emergency room. Although identification of the cause of water loss is important, attention must also be given to identification of the reason why the patient is unable to replace the water losses, such as impaired thirst, altered mental status, or a primary neurological disorder. Severe ECF volume depletion, especially when accompanied by hemodynamic compromise, is a first priority and should be corrected with 0.9% saline. Subsequent replacement fluids should be hypertonic. Replacement of water deficits involves 3 steps: calculation of the approximate water deficit, administration of the water replacement at a rate sufficient to correct the hypernatremia, but slowly enough to avoid cerebral edema, and frequent rechecking of the sodium concentration to monitor therapy.